So now we would start the next topic, that is ptosis. Now what is actually the ptosis, the definition of a ptosis? Please see this photograph. In this photograph you can see that the right eyelid is basically covering a part of cornea, around 2 millimeter of cornea, and the left eyelid is covering more than 2 millimeter of cornea. So the definition of ptosis is basically when the upper eyelid covers more than 2 millimeter of cornea, then it is called ptosis. Okay, so the ptosis, as the word basically says, that there is a drooping of eyelid. So this is general definition, drooping of eyelid, and upper eyelid which is covering more than 2 millimeter of cornea, this is the specific definition of the patient. Now how many types of ptosis are there? Ptosis can be basically classified into two types: the congenital one and the acquired one. Let's see what are the various causes of the congenital ptosis. So first and the most common type of congenital ptosis is the congenital simple ptosis. Sometimes it can be associated with the various other oculomotor abnormalities. As you know, the LPS and the superior rectus are the muscles which are supplied by the third nerve. So sometimes there is a third nerve palsy, sometimes there is a superior rectus abnormality that can lead to the ptosis. So ptosis associated with various oculomotor abnormalities like a double elevator palsy, like a superior rectus muscle underaction. Okay, sometimes it can be associated with some congenital syndromes also. The most common one and the most commonly asked one is called BPES, the blepharophimosis epicanthus syndrome. Okay, sometimes it can be there associated with abnormal neural connection. So you may be having a ptosis which improves on opening the jaw. So this is basically called synkinetic ptosis. Okay, and we can have sometimes because of the misdirected third nerve. So these are some causes of congenital ptosis. Now let's see what are the basic features of the congenital ptosis. The most important one that you have to remember is that not only there is a drooping of eyelid, the drooping of eyelid with the short form EL is associated with diminished or absent lid crease. I request you to please note this point, very important. Now what this actually means is when you can see the eye and you can just observe it that there is a lid crease here. In the patients who are having a congenital ptosis, let's see, you can see this patient. Here you are having a lid crease here, but in this eye you cannot see the lid crease. So lid crease has not basically developed. So that is a very important point in a patient of a congenital ptosis. And there is a lid lag also. So whenever patient sees down, the eye which is having a ptosis, the lid would lag behind. Okay, so let's say I am seeing straight, now I would see down, so my other eye would basically go down, the eyelid would go down, but this would be having a bit of restriction. So this is called a lid lag. So lid lag on down gaze is a very important feature in the patient of a congenital ptosis. let's talk about the acquired ptosis. Acquired ptosis, the most important reason that you have to remember is myasthenia gravis. As I told you, it can be there after a third nerve palsy as well. It can be due to any mechanical effect due to lid tumors. Sometimes it can be traumatic as well. So the most important one that you have to remember is the myasthenia gravis and the acquired third nerve palsy as the cause of the acquired ptosis. Okay, so let's talk about classification. So classification basically is mild, moderate and severe. Mild is around 2 millimeter, moderate is around 3 millimeter and severe is around 4 millimeter. Now what actually this means? Now this means that, let's say this is my cornea, okay, and we have a pupil in the center. So if the eyelid would basically bisect here, so it would basically have a lot of effect on the vision of the child. So if the patient comes with a severe ptosis and severe congenital ptosis, so this patient, because of this severe ptosis, would have a non-development of the visual pathway, and this can lead to the most common complication of congenital ptosis, which was asked in the exam, that is amblyopia. So definitely you may wait for a surgery in a patient of mild ptosis, but in a patient of severe ptosis, your threshold for doing a surgery would be low, because we do not want this patient to go into amblyopia. Okay. Now we have a term which is called marginal reflex distance. Now what is the meaning of marginal reflex distance? Please remember, it is the distance of upper lid margin and corneal light reflex. Usually it is told that this distance should be around 4 to 5 millimeter. Now what it actually means, please understand. Let's say this is my cornea, this is my pupil, okay, and this is my eyelid. Now here, this distance, okay, this distance from the center of the eyelid to the center of the pupil, this is called marginal reflex distance. Okay. So if the marginal reflex distance is less, so this means that the patient is now having the ptosis. Okay. Now the next thing that you have to remember is how to basically do correction of the ptosis. So as I told you, in severe ptosis, in a congenital ptosis, your threshold for doing a surgery is low. In acquired ptosis, most commonly like in the Marcus-Ganjow winking phenomena ptosis, which is a congenital ptosis, and a patient who is having a neurogenic ptosis or a myasthenia gravis, in that patients your threshold for doing the surgery is higher, because these patients you do not know how much would be the correction after the ptosis surgery. So we would come to the important point, the various types of the surgeries. The most important one that you have to remember is the levator resection. As I told you that the most important muscle for the elevation of the eyelid is the levator palpebrae superioris. So what we do is, whenever we do a resection, we basically strengthen the muscle. So we strengthen the muscle. So levator resection is a very good option in the patients who have congenital ptosis and they have a good LPS action. So there is no LPS atrophy in that patients. In that cases, levator resection and plication is a very good surgery to do. Now sometimes there is a milder ptosis. If there is a patient who is having a mild ptosis, we do not want to do such a big surgery. In that cases, what we can do is, we can do a surgery which is called Fencinella Stewart surgery. Please remember the name. So it is done in mild cases, and also be done in the mild ptosis which is there in the Horner syndrome as well. Okay, then comes, let's say, your surgeries which you have done in a patient that has failed, okay, or if there is a patient who is having not a very good action of the LPS. In that cases, you have to basically make something inside the eye or eyelid and stretch the LPS completely. Okay, so you want to make a bypass channel which can now not only the LPS but that basically that sling or that tissue would basically elevate the eyelid. So that is called a frontalis sling surgery. So frontalis sling surgery, you should remember, should be done in the patients of failed LPS surgery, or let's say patient is having a traumatic ptosis where the LPS is damaged, or in the cases we have a very bad or poor LPS action. Okay, you do not have to go into details of how to do the ptosis surgery, but remember these names of the surgeries which can be asked